name is Dr. Rebecca Gilbert, and I'm Chief Mission Officer at APDA, and it is my pleasure to welcome you to this special keynote session entitled Pain Management in Parkinson's Disease, a topic that I know so many of you want to hear lots of information about. Our expert speaker is Dr. Bianca Carson. Dr. Carson is a neurologist and interventional pain specialist at Boston Medical Center in Boston, Massachusetts, and she serves as pain liaison to the gerontology department. We are so happy to have you here, Dr. Carson. Dr. Carson will also answer questions live after this presentation, so be sure to include your questions in the chat. Dr. Carson, the stage is yours.
Awesome. Well, thank you so much for the introduction. Hello, everyone. I'm happy to be here today. As Dr. Gilbert mentioned, I'm a pain neurologist who specializes in as pain liaison for both the gerontology, but also rheumatology and sports medicine departments here at Boston Medical Center. We're going to start with the pain management in Parkinson's disease conversation. Next slide. So financial disclosures, I have none. Moving forward, we're going to talk about the outline for the presentation. And so we're going to start with the history and prevalence of pain in Parkinson's disease. From here on out, Parkinson's disease will be labeled as PD in my slides. We're going to discuss the pain definitions and certain terminology related to pain in context of Parkinson's disease. We're going to discuss pathophysiology of pain. We're going to review classifications of pain. And then lastly, we're going to review treatment modalities, both pharmacologic and non-pharmacologic treatment modalities with regards to pain management. So starting off with the history of pain in Parkinson's disease, I just want to first start off saying that it's not a new concept. James Parkinson, who famously wrote the essay called The Essay of the Shaking Palsy, which really in accurate detail and very thorough detail discussed about the clinical manifestations of Parkinson's. And even back in 1817, documented that there were pain-related symptoms related to the premotor symptoms of Parkinson's disease. And even though it's a well-known, or I will say well-received concept, pain in relationship to Parkinson's disease is still an often undertreated or overlooked component of pain. It's often even seen as something else as other than Parkinson's, so it's not really addressed when you're talking to your neurologist or other healthcare providers in relationship to Parkinson's disease. So because of that, the prevalence of pain has not really been tacked down in terms of percentage, a specific percentage. Earlier studies even had a wider variable of 20 to 80%. More recent studies are estimating about 65 to 89% of patients with Parkinson's are dealing with some sort of pain. And so based on the increasing age and the increasing prevalence of Parkinson's disease, it's estimated that by 2030, there will be 3.7 million patients with pain worldwide that will remain undertreated or untreated. Next slide. So before we go into terminology, I wanted to make sure that we review the definitions of pain. And so all the definitions from here on out would be provided by the International Association of the Study of Pain, also known as IASP. And so the first definition of pain they constructed was back in 1979, which they define pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And the reason why I want to at least go back to what the definition was in 1979 is to also discuss that impact in terms of not from just a clinical presentation, but from a research presentation, even colloquially how we define what pain is and how we even acknowledge pain. Even as a neurologist, a lot of our training is dedicated to what we call localized lesion, find out exactly which brain tissue or which type of structure is contributing to the pain. And although that is an aspect of pain, it does not have a complete aspect of what pain can be. Because although there are some areas that we can discern it by tissues, there's a lot of areas that we cannot. Pain, as we all know, is a very subjective experience. It's an emotional experience where it could be very wide range in your duration, your quality. And so having a need to revise that was really important. And so with the AISP, they did a lot of revamps of the definition. That definition, 1979, held on until 1994, and then I believe it changed again in 2011. The most recent revision of the definition of pain is as follows: an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And with that, they had 6 additional notes to make it more inclusive of the different types of pain that we'll talk about today. So the first note: pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. And then second note: pain and nociception are different phenomena. Pain cannot be inferred solely from activity in sensory neurons. And I'll talk about nociception in a little bit in the next few slides, but nociception, again, is when pain is derived from a damage of a tissue. But the reason why they need to separate that is even if there is damage from the tissue, because pain is an emotional response, if you do not have an emotional component associated with that damage or vice versa, you can't necessarily quantify that that's just pain or like only pain if it has if there's no actual connection to structural changes. The third note is: through their life experiences, individuals learn the concept of pain. Next one is: a person's report of an experience as pain should be respected. The fifth one: although pain usually serves as an adaptive role, it may have adverse effects on function, social, and psychological well-being. And then lastly, verbal description is only one of several behaviors to express pain. Inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. Additional terminology in pain that, again, reviewed by AISP is nociceptive pain, which, again, kind of anchoring on what that 1979 definition was, is that that's pain that arises from actual or threatened damage to non-neural tissue and is due to the activation of nociceptors. Nociplastic pain is pain that arises from altered nociception despite no clear evidence of actual or threatened tissue. And then we have neuropathic pain, which is pain caused by a lesion or the disease of the somatosensory nervous system. And depending on the location of the nervous system, it would be called either central neuropathic pain if it involved the central nervous system, or peripheral neuropathic pain if it involved the peripheral nervous system. Next slide. So going into the pathophysiology of pain in Parkinson's disease, I first want to start off that it's multifaceted and complex. This by no means will be an exhaustive list of all the pathophysiology that's involved, but I hope that in this lecture we can talk about at least about some of the few select key role players of either the structures or the neurotransmitters, and also discuss how that pathophysiology influences treatment, the pharmacologic treatment modalities that we use today for Parkinson's-related pain. So starting off with the basal ganglia, which is the structure that involves in processing nociceptive input, but also integrates that incoming nociceptive information to help coordinate those motor responses in terms of pain avoidance and reducing pain-inducing behavior. So for example, if you were to prick your finger, automatically you would have a sensory afferent neuron that goes to the brain, processing it as pain, and then you will have an efferent motor response that elicits your body to have a withdrawal stimulus to remove your finger or whatever body part that's being injured from the offending agent, and also learn to adapt and see if there are any other things that resemble that mechanism before. So that, in a sense, is what the basal ganglia main purpose is to coordinate those type of movements where it relates both sensory and motor neurons to avoid from feeling those type of pain symptoms. Moving on to your I'll go back for a second. So moving on to your neurotransmitters. Dopamine, as we all know, is a really big component of the pathophysiology for Parkinson's, the loss of dopamine specifically. We're going to go about that more in different slides, but for now, dopamine directly modulates pain signals by changing the activity of neurons in the spinal cord and brainstem that processes pain information. And then glutamate, which particularly the hyperactivity of glutamate, can send excitatory signals to pain fibers. The last two neurotransmitters I wanted to discuss before going into more pathophys is acetylcholine, which acetylcholine is a neurotransmitter which regulates nociceptive transmission at the level of the spinal cord via pre- and postsynaptic mechanisms. And acetylcholine is interesting because it acts differently depending on the receptor. But for the purpose of this talk, we're going to generically say that elevation of acetylcholine levels in the spinal cord induces analgesia or a pain alleviating effect, versus a decrease of acetylcholine levels or activity decreases threshold for pain. And so also interesting to know is that in the ratio of dopamine to acetylcholine, if you have too much acetylcholine and not enough dopamine, that can actually induce rigidity or tremor, which are non-motor symptoms associated with Parkinson's disease. With the serotonin, as we know that there's Lewy body pathology that affects the substantia nigra, it also affects the raphe nuclei, which is the main structure that produces the serotonin. And so serotonin can play a role in both pain perception and the modulation, typically with non-motor symptoms such as mood, fatigue, and sleep disturbances. Those are all contributing factors that can affect pain as well. So on the left, we have a diagram from an article that reviewed the pathophysiology of pain in relationship to dopamine levels. So again, when there's a degeneration of the substantia nigra, you have a loss of dopaminergic neurons that is processed in your striatum. And in your striatum, you have both a direct pathway and an indirect pathway. With your direct pathway of the striatum, it goes directly to your globus pallidus interna, which those low levels of dopamine leads to low levels of GABA. And those low levels of GABA in the globus pallidus interna then goes to your thalamus, which produces an excitation of glutamate. And glutamate, when it's really high, actually produces excitatory signals or stimulus to your pain fibers, specifically your pain fibers, delta A or your C fibers. Now, going back to your delta A is when those are myelinated fibers. So with myelinated fibers, they have very fast transmission. Again, going back to the pricking of the finger, automatically you know that you're in pain and you withdraw very quickly. Those fibers typically represent sharp, sometimes stabbing, prickling, sometimes burning, where you immediately will withdraw your finger. Versus C fibers, those are unmyelinated pain fibers, which means that they have a slower transmission and a slower transduction in comparison to your A fibers. So for example, if you were to stub your toe, you may have an initial response where you want to move your toe, and you're no longer in the perceived threat of, injury, but yet and still you still have a dull, achy, sometimes throbbing sensation that no longer involves just your toe, but sometimes your whole foot. That's kind of a picture of what C fibers are. And so in essence, we talked about how the direct pathway ultimately increases your glutamate, which produces pain fibers. Your indirect pathway does the same thing, just in a different way, where those low levels of dopamine in your indirect pathway that goes to the striatum to then your globus pallidus externa actually produces high levels of GABA. And with those high levels of GABA, because it doesn't go directly to your thalamus, it stops by at your subthalamic nucleus. It actually produces low levels of your glutamate in the subthalamus. But as some of us may know, the subthalamic nucleus disinhibits the thalamus. So because it's low levels of GABA, of glutamate in the subthalamus, you actually produce high levels of glutamate in your thalamus, which again kind of proliferates this pain fibers. So I'm sorry if that was really technical, but I just want to at least put some of these neurotransmitters kind of like in the forefront, because we will be kind of circling back of why we use certain medications. So this is in terms of the classification of pain. This is defined by the 4 classifications, where we have 5 different classifications for Parkinson's-related pain, which is musculoskeletal, dystonic, akathisias, neuropathic, or primary central pain. So musculoskeletal pain is the most frequently reported type of pain in Parkinson's. It's often due to the rigidity, postural changes, gait disturbances, or akathisias. Even looking at this animated picture on the right with a patient with Parkinson's disease, you can see that there are some biomechanical changes that may be that alter over time. So you can see that there's more of like a stoop posture with the lumbar and cervical spine that's more flexed. You have the shuffling of the gait, which produces a shorter stride, producing more strain on your hips, more strain on your ankles, more strain on your knees and your back. You have more of a decreased mobility of your arms with the decreased arm swing, therefore having more of an internal rotation of your shoulders, which really puts a lot of pressure on your shoulder girdle, and the reason why shoulder pain is a very common presentation for musculoskeletal pain in Parkinson's disease. So in addition to the shoulder, that's why some of the most effective areas include your spine, your neck, ankle, hips, and your shoulders. So treatment for musculoskeletal-related Parkinson's disease pain is first optimization of your medication. So of course, we want dopamine. Dopamine in our system keeps the body moving. It helps with prolonged standing, prolonged walking, to transition from sitting to standing. Also, sulfonamide, which is a MAO-B inhibitor, helps prevent the breakdown of dopamine, but also helps decrease the glutamate, which again, increased glutamate equals increased excitation to the pain fibers, and the converse, decreased glutamate, reduces those signals of those pain fibers being put out into our bodies. Physical therapy, cannot stress this enough, where because we have biomechanical changes and gait disturbances, that alone will alter our kinetic chain, and therefore we'll have different body structures that are trying to compensate for our normal mode of function. So having physical therapy where they can look at your biomechanics specifically and work on programs for strengthening and conditioning, looking at range of movement, is really, really crucial, in addition to continuing those home exercises afterwards or during. Non-steroidal anti-inflammatory agents, I would say, would be first line for musculoskeletal pain. And honestly, in my practice, this has already been established with either their primary care doctor or their movement disorder specialist. In this case, I tend to try to optimize by using like a longer acting agent if feasible, meaning that there's different half-lives that different NSAIDs can give. Some of them are 4 hours, some of them are 6 hours. We also have NSAIDs that can, have a half-life of 24 hours. So of course will last longer in the body. Next, we have muscle relaxants. And again, it's just because we have different strains of like cervical paralumbar muscles or cervical paralumbar muscles that could be really tight and overall engage. To kind of help them relax and kind of get back into a posture where it's not as contracting for a longer period of time. We have our tricyclic acids, which can include our amitriptyline, our nortriptyline, our desipramine, which have a serotonin effect, which helps with the perception of pain and dealing with other factors such as mood, fatigue as such. Our anti-seizure medications, that's our gabapentin and our Lyrica, which I'll talk further in, like our neuropathic type of neuropathic pain related to Parkinson's. And then in terms of intervention, we have trigger point injections. So again, those are the spasms of your muscles. Your muscles are spasmed, they interlace just like this. And as they spasm, they continue to form and they can bulge. So the point of a trigger point injection is to use local analgesics such as lidocaine and bupivacaine into the belly of the muscle to help them relax and reform back where they're not in so much in a contracted mode. Other interventions can involve ultrasound-guided or fluoroscopic-guided injections, primarily in joints such as your shoulder, sometimes your hip as well. So the next form of pain is dystonic pain. So dystonia is characterized by involuntary muscle contractions that can cause twisting, repetitive, or sustained movements. It can affect various regions, including your extremities, like your hands or feet or your face. The picture on the right actually shows a dystonic foot that can be seen in Parkinson's, and that specifically the left foot, where you have the curling of the toes underneath. You have your big toe that can extend upward or outward. You can have your foot that inwardly starts rotating. And so also just want to bring out that these different types of pain classifications can result in, forming or inducing other pain in different classifications. So for example, with the inversion of the foot, you can imagine how that can affect, someone's stance or walking, where that can then affect like their hip or their ankles or their spine. And so with dystonic pain, it can be spontaneous. Sometimes it can even be triggered by movement or not triggered by movement. It can occur early in Parkinson's disease unrelated to medications, but it can also occur later in Parkinson's disease, often related to medications, typically during the off period or the off interval. So treatment for dystonic pain, if the pain occurs during off periods, we can adjust the levodopa to reduce the interval of those off times. Amantadine can also help with the off-related dystonia. And so we also have anticholinergic medications, which again, going back to that hyperactivity of the colon, of the anticholinergic activity versus dopamine, you can have that increased rigidity or tremors, which is why those anticholinergic medications are helpful. Using antispasmodic medications can also help. In some cases, you can consider Botox in the affected limb or the extremity, as well as deep brain stimulation at the level of subthalamic nucleus or the internal globus pallidus. Akathisia. So this disorder is characterized by inner restlessness and persistent urge to move or change position, not to be confused with restless leg syndrome, although it can present very similarly. One, restless leg syndrome typically happens at night, and when you have the urge to move and you move, you have a sense of satisfaction. Akathisia, you have the urge to move, but you don't necessarily have that satisfaction. So although it may not be painful, it can be severely disabling and affect your activities of daily living, as well as wanting to socialize. So for these treatments, we consider levodopa therapy to reduce those off intervals. Akathisia was historically been attributed to your first generation antipsychotics. Using a more atypical antipsychotic such as clozapine reduces the risk of those akathisias. Other things to consider are beta blockers, your anticholinergic medications, vitamin B6, and low-dose mirtazapine. Next, we're going to discuss the peripheral and radicular neuropathic pain. I would say if musculoskeletal is the most common, this is probably the second most common. And again, neuropathic pain is the irritation of the nerve or nerve root, depending on the position. The location. It could be peripheral if it's the nerve, or the radicular if it's the nerve root. And it can present with paresthesia, which is a numbness, tingling sensation, as well as a sharp, burning, electric sensation. And this type of pain usually travels along the distribution of the nerve or nerve root, which for us neurologists makes it very gratifying in the sense of going back to localizing the lesion. We can, typically patients will say like have pain in the back, and it goes into like this outside part of the leg. So we can define that in terms of by the dermatomal distribution. And again, neuropathic pain can stem from the changes of gait and the mobility in your biomechanical structure or forces that have been altered. So again, with having your back in complete flexion or your neck in complete flexion, that does can irritate the nerves in a different way. And so moving on to the next slide where we talk about treatments, we can talk about a lot of first-line treatments are similar to what we did in musculoskeletal, with the exception of the anti-inflammatory medications. So tricyclic acids, or the TCAs, can be helpful, particularly for nerve pain. And then anticonvulsants, which is the gabapentin and pregabalin, are really helpful as well. Again, going back, the gabapentins and the pregabalins help with decrease of the GABA, which therefore decreases the glutamate, which then decreases the pain fibers that we talked about earlier. We also have the SNRIs, or the serotonin norepinephrine reuptake inhibitors. Those are your duloxetine, such as Cymbalta, or your venlafaxine. For peripheral pain, you can also use topical agents such as lidocaine or capsaicin patches. As a third line, for some places, I did see some articles, would be for opioid agonists. First, starting off with your partial opioid agonist, which would be like your tramadol or your tapentadol. If in more extreme cases, a stronger opioid agonist can be used as well. And then lastly, in terms of interventional procedures, we can consider ultrasound-guided or fluoroscopic-guided injections, which would normally involve epidural steroid injections being probably the most common. We can also use nerve block injections as well. Lastly, talking about central pain. So central pain is described as heating, burning, pins and needles sensation. Pain locations can vary. Usually the limb most affected by Parkinson's disease is involved. The cause is not well understood, but it does, or at least it's suggested to involve some dysfunction in the pain processing centers because it tends to coincide with the off intervals. And so similar as before, we have our SSRIs or SNRIs, like our duloxetine, venlafaxine, our TCAs, such as the nortriptyline, amitriptyline, or our anti-epileptic drugs or anticonvulsives, such as gabapentin, Lyrica, sometimes even lamotrigine. You can consider DBS. Cannabinoids has been a hot topic for the last few years where it seems like there could be some studies that are suggestive, but hasn't really been a clear consensus of across the board with cannabinoids. So in summary, just want to do a quick pharmacologic treatment algorithm for Parkinson's disease. And this is broken down into like the three types of pain that we talked about earlier: central pain, nociceptive pain, or neuropathic pain. Of course, first is to optimize medical treatment for motor and non-motor symptoms. So again, just optimizing the dopamine levels as best as you can. The non-motor symptoms in terms of, managing if this is fatigue, is this is more so mood disturbance, whether that's depression or whether that's anxiety, because that also plays a role, whether it's sleep disturbances. And then looking into central pain, we look into like the non-opioid analgesics, NSAIDs, of course, cannabinoids in question mark of possible therapeutic benefit. In some studies still have shown some things that could be controversial. We have our antidepressants, our anticonvulsives, as well as our opioids. With nociceptive pain, again, we're looking for similar things: non-opioid analgesics, your NSAIDs, opioids with low potencies, which is your tramadols, and then if needed, opioids with higher potencies. And lastly, your neuropathic pain, which looks at the antidepressants or anticonvulsives, mainly because those have a nerve pain relationship first, combination thereof, or then opioids. So for non-pharmacologic treatments, formal physical therapy is highly recommended because, again, you have someone who can supervise, who knows the biomechanics and knows how the alterations biomechanics can stress certain joints or muscles other than others, and can make a more curated exercise program to help you with the physical conditioning or mobility. I think in my personal practice, I've seen that aquatic therapy is actually underutilized. I think it would be a great form where, particularly when gravity is pushing you down, and particularly if the pain is in the weight-bearing joints, such as like your spine or your hip, where having that buoyancy gives a little bit more forgiveness, where you can really, expand in like the mobility and strengthening without having the brunt of gravity always pushing you down. Regular self-guided movement. I cannot emphasize this enough. The type of movement really doesn't matter. It's just something as long as you like to do and something that's sustainable to do. So whether that's dance, whether that's yoga, Pilates, Tai Chi, I think whatever that encourages you to keep moving would be one of the best non-pharmacologic treatments. For acupuncture, I think some people not hate it. Some people love it. Some people don't think anything of it. I think it is worthwhile to try, particularly if you've tried different medications or if you have an adverse effect to medications, where it can promote mainly your musculoskeletal and your neuropathic type of pain. And then also as well as massages for myofascial pain. Cognitive behavioral therapy. So cognitive behavioral therapy, I think, helps with the perception of pain and your outlook of pain, which therefore helps with pain modulation. There are some questions about transcranial magnetic stimulation to see if that helps with pain. I also work with patients with concussions and like with the post-traumatic headaches and anxiety that's associated with that. There's been a lot of evidence in terms of neuromodulating certain factors with a wearable device and seeing how that translates into your perception of pain and improvement of pain, where there's a lot of upcoming studies in the realm of Parkinson's with that as well. I've already discussed in terms of cannabinoids of how that's been under review. And then lastly, mindfulness and meditation. And with that, when we do mindfulness and meditation, we have what's called autonomic pairing, where we have a sympathetic nervous system, which our pain is mainly derived from, and then we have a parasympathetic nervous system. And so with the mindfulness, we're able to kind of pare down our sympathetic nervous system to match with our parasympathetic nervous system, and therefore can be a useful tool, what I like to call in the toolkit to help with pain management. So I believe that is my last slide. So if there are any questions,
there are a lot of questions. Thank you so much for all that amazing information. The questions are coming in fast and furious. So thank you so much so far, and we're looking forward to the answers to our audience's thoughts. So the first is from Keith. And I know this is a question that I get asked all the time, so I'm really curious what your answer will be. How do I know if a pain is related to my Parkinson's or just plain old age?
Good question. Good question. And honestly, it would be hard to delineate. And I actually don't think that we should focus too much on delineating. I think that pain is an integral part of Parkinson's, whether or not it came from it or not, where it does affect your quality of life, and also affects in terms of your movement, not just from a physical aspect of limiting, but the psychological and emotional sequela that can prevent you from doing further movement, where it can have its own cascading effects. So good question. I don't know the answer to that, but I still think that either one just treat it accordingly.
Fantastic. So Keith continues in his question, which is a good one as well, which is, so if you have pain and maybe it's related to your Parkinson's, is it worthwhile to try increasing Parkinson medication and see if that helps?
I would say yes. Of course, I would defer to a movement disorder specialist because you can have dyskinesias related to increase of dopamine. But I do think that would be a reasonable first approach, is to optimize your Parkinson's related medication to see if what are your off intervals, and if possible, if we can reduce those off intervals, especially if you feel like there's a correlation of increased pain in those times where you feel like the medications are wearing off.
Yeah, that makes a lot of sense. Thank you. So this is a great question that actually came in a little bit earlier, which is, at which point during the treatment course should a person with Parkinson's consider a referral to pain management?
Good question. So I really think it depends on terms of what your practice is. So how, at least in my practice, it's an academic medical center where we have subdivisions of neurology. Typically, when someone has pain, our movement disorder specialists are pretty well involved, where they might even just walk over to the next exam room and kind of knock on my door and it's like, hey, I've tried this medications. Can you see them? I would say that at least minimally try the physical therapy, the NSAIDs, which is a non-steroidal anti-inflammatory medication, the optimization of your Parkinson's related medication. If your pain symptoms persist, again, pain is subjective, but I would say at least like a 5, 6 out of 10 ongoing, I think it would be worthwhile to see a pain specialist.
Okay, great advice. We have a really good question from Gerald, and maybe some other people in the audience are thinking this too after hearing this. I am basically pain-free 8 years after my diagnosis. Does that mean I've avoided this problem, or do I have to keep worrying about that this may develop?
Good question. So again, in terms of that prevalence, it wasn't 100% prevalence of pain in terms of premotor type of symptoms. I think with that said, a lot of these symptoms that we mentioned can be age-related in and of its own. in and of its own right, where as we all get older, we're all going to have different changes in our biomechanics. So I wouldn't necessarily say like visually monitor to see if it's around the corner because of your Parkinson's, but in general, practicing, mobility, range of movement, flexibility, I think will prolong in terms of like pain mediation as well as sustainability over time.
Great. So we have a question from Mary Beth. She receives Euflexa injections in her knees, and she's wondering, why don't I get these injections in other parts of the body, like my hips? What would you say to that?
What's the name of it? I'm sorry.
Euflexa. I don't know if that's a
I have to look up
common type of injection.
Google would be my friend. Okay, so it looks like it's like an analog for a synovial fluid. That, at least for my very quick Google search. That's a good question. So I would say our shoulders as well as our hips are what we call ball and joint sockets. So we have the circulatory mobility of our shoulders in the same way as our hips. That I would say it has a more, it's not as forgiving in terms of the synovial fluid that's needed to kind of lubricate that area. I cannot speak specifically of why not hips versus that, but I would imagine that it depends on what's the level of osteoarthritis or what's the level of like the synovial fluid that's helping lubricate, and maybe it's just not needed in that area for you at this time.
Okay, great. So this is a question that I think is on a lot of people's minds as well. So if you have pain, and this is a pain that you are worried will get worse when you exercise, should you go ahead and exercise, or should you hold off on exercise until the pain is better?
Good question. So
Yeah.
this is what I tell my patients. For people who weightlift or don't weightlift, I'll explain the analogy. If you weightlift, you know that you're at a good weight when around, if you're aiming to do 10 or 12 reps, you may feel some struggle, or like you have to really motivate yourself around rep 8 to get to rep 10, or rep 10 to get to rep 12. So I equate, your movement in the same way, where if you're automatically feeling pain, very early onset, that means, right now you need to rest. But I think it's okay for you to allow your body to engage in movement, stay in that uncomfortable stage, for a little while. I know a little while is not like a scientific term, but like to the point where you feel like you're like that rep 8 in relationship to rep 10, to then at least retrain your body to say, it's okay. Pain is okay to feel. Like, this lets me know that it is movement. We are moving with the mechanisms without overdoing it and hurting yourself.
So a related question. So what if you find that the exercise, you do your exercise, you go to your physical therapy, and then you're in pain afterwards? Is that something to be expected? Do you keep going to physical therapy? If it seems like the physical therapy is actually causing the pain?
Good question. And this is something I do come across quite a bit. I think one is a check-in in terms of with your physical therapist of how you're feeling afterwards, so they can have a modified program where you're not feeling that. Sometimes I would even recommend what's called pre-medicating, meaning using like a Tylenol or an ibuprofen before you start the exercises, so it can kind of keep the inflammation at bay before starting, and so allowing you to do the mobility and strengthening needed to ultimately decrease your pain.
Okay, that's a great tip. Thank you. So we have a great question from Dee, which is, how does Parkinson's affect knee replacement surgery? So the Parkinson's kind of increase your risk for needing surgery. Are there any things to watch out for if you are told you need knee replacement surgery and you have Parkinson's? What are your thoughts on that?
I don't know necessarily in terms of like the prevalence of knee surgery in relationship to Parkinson's, but from a theoretical basis, I would imagine that if your biomechanics have changed to the point where you have a stoop posture and you're shuffling gait, that means you are bearing a lot of brunt or force on your knees. I would say that in terms of the question was like, how does it affect in terms of knee surgery? I'm sorry, Dr. Gilbert, in terms of like the prevalence of it, or?
And also, once you're undergoing knee surgery and you have Parkinson's disease, are there any specific things you should consider that you may not have to consider if you do not have Parkinson's disease?
I would say things to consider would be the rehabilitation in terms of like retraining on balance and gait or your walking mechanics. That probably would have to be a little bit more considerable, something to put in consideration, just because the coordination of movement may not be as quick to kind of like rebalance or regain your step if you were to lose balance, which we do utilize like our knee and ankles a lot for that. So I think like using a physical therapist who can support you in what we call big movement type of tactics would be helpful.
Yeah, that's a great answer. And that actually answers Jose's question, which just came in with Jose recently had both hips replaced, and the right side seems to be lagging behind the left side because of his Parkinson's. So similarly, kind of getting a physical therapist involved to take into consideration the Parkinson's during the rehabilitation is also the answer there.
Yeah. And I also want to mention, I keep on mentioning physical therapy, but also like shout out to occupational therapy as well, because that really helps with your function of movement in everyday life, where they can also look at mechanics of like, if you're dressing yourself, if you have to, meal prep. So I've been using physical therapy heavy, but I also want to, make sure I say occupational therapy as well.
Absolutely. Some people had questions about some of the non-pharmacologic approaches that you mentioned. Is there any sort of go-to one? You've gone to the pain management person. You're doing your best with physical therapy and movement. You listed a whole bunch of other sort of modalities. What would be your next go-to?
Outside of those, or like within those?
Of the ones you listed, which is kind of your favorite, or is there?
Good question.
Some kind of algorithm you use?
Good question. So I don't necessarily have a treatment algorithm. I'm a big sports fan, so I give, when I say this, I give what the defense gives me, meaning that if it comes up that there's a psychological, emotional stressor, I think I probably would lean heavy on more like cognitive behavioral therapy, mindfulness meditation. If I kind of hear that despite like medications or like in terms of like some of the medications might make you too drowsy or for sedated, or you're having some cholinergic effects like dry mouth, I would lean more in terms like maybe massage or acupuncture. I think across the board, I'm hoping it's coming across that I think movement in general across the board is what I probably recommend the most.
So that's very helpful. I mean, I think a lot of people, are happy to hear that there is something you can do. It isn't necessarily some newfangled device, but just kind of the basics can get you a long way. So thanks for that. We have a great question from Suzanne, which is some of her pain issues seem to make her Parkinson's tremor worse. So do you find that there's kind of the Parkinson's can make pain worse and the pain can make the Parkinson's worse, and how do you kind of talk to people about that issue?
Absolutely. So like I at least try to convey that pain is a very multifaceted, complex pathway, diverse pathways that have like, social and psychological, emotional stressors and sequela. I would say that in terms of with that, like a multimodal approach is definitely needed. So I try to emphasize that it may not be one medication, may not be one type of therapy, may not be one type of injection, but it might be a combination of, cognitive behavioral therapy with the optimization of your medications, with physical therapy and occupational therapy, maybe doing trigger point injections or the like to try to help manage. But it is, it's not like a simple algorithm, but I think it does take a marathon, multi-level or multimodal approach.
Fantastic. Craig has a great question, which is there a particular type of painkiller, NSAIDs or even opiates are involved as well, that you have to worry about constipation? So a lot of people find that some of these pain medications are causing or increasing their constipation. So how does that play into the medications that you prescribe?
Good point. So in this pain practice at Boston Medical Center, we actually do not prescribe any opioids, but I didn't want to give a disservice saying that that's not a practice. So any opioid agonist does have the potential side effect of constipation because it does decrease your gastric motility. So I would say across the board as a class of medications would be your opioid agonists. I also think your TCAs or your tricyclic acids, which could be your amitriptyline, your nortriptylines, the spiramines, can also have a sequela of constipation as well. Your gabapentins or your Lyricas can have that, as well as a potential effect of urinary retention. Again, this is all dependent on dose. This is dependent on what your creatinine or your kidney functions look like. For some of them, what your liver function. So it's not an end all be all, but something that I would say you should consider and talk about the risk and benefits with your provider.
Great. Okay, so good to know. So lots to consider. You may get the medication and then it affects some other part of your Parkinson's. It's all very complex, as you said. And it's great to have people like you who can help sort it out for everyone. So we have a great question coming from prior to the session, which is, what do you think of the role of family members to participate in helping to alleviate pain? What would you say to a care partner who really wants to help?
I think absolutely crucial. I think your social support, whether it's family members, whether it's friends, whether it's in terms of spirituality, religion, I think does play a huge component in terms of your pain management from physical, but also, like we said, pain is an emotional experience. So having that, it's very hard to dissociate and isolate it into just like tissue damage or to just pain severity numbers and what makes it better, what makes it worse, without necessarily the experience of how you feel with pain and how you feel in support when you're in pain. So can't emphasize enough.
Fantastic. So many people are interested in knowing about supplements. Are there any sort of things that you can buy from the natural health store that you can add on to some of the things you've talked about? Any advice you can give to people who want to go that route?
Yeah, good question. So turmeric, I feel it has anti-inflammatory properties. Black pepper is another thing to consider, and from a supplement standpoint, I think just making sure you're on your complex vitamin B as in boy, because that tends to help with, I would say, with neuropathic pain, or the precursors to the myelin, which I won't go too much in that biopharmacology again, but can help with the nerve pain. Can be some supplements that I've seen and have used in my practice to kind of help with pain management.
Great, thank you. So people are asking about the cannabinoids that you mentioned, so the medical marijuana route. Any more pointers or restrictions that you may want to share with the group about using medical marijuana for pain relief?
Yeah, so right now it's a really hot topic. There hasn't been any, I would say, an overall shared consensus. But the idea is that the cannabinoids really dwell in those serotonin neurotransmitter pathways, the dopamine neurotransmitter pathways, which is why theoretically it's been postulated at least that it should help with with the physical pain, both musculoskeletal and neuropathic pain. But also there's some other ideas of is there contributing to what we call cognitive dampening, meaning in producing more cognitive disturbances with Parkinson's, or disorientation, where balance may be a little bit more question, and you have a sequela of having a higher risk of falls, which then produces more pain. So I guess that would be my additional tidbit.
Yeah. So again, watching out for the pros and cons of all these different options. So thanks for that. We actually are at the end of our session. That went really quickly. We had a ton of engagement from our audience. So thank you so much. We have time for one last question. So I'm going to get in the question from Gerald, who wanted to know a little bit more about trigger point injections. What are they? How can they be helpful?
Okay, yeah. So trigger point injections are injections of local anesthetics, typically bupivacaine and lidocaine. If you've ever had a dental procedure, it was Novocaine. They're all cousins, basically, with different onsets and durations, where the idea is that when you have muscles that are overly engaged or contracted, they form into what we colloquially call knots, and that can restrict your movement. So with trigger point injections, you inject into the belly of the muscle, where I'll be using my hands, where it's really bulging like this, the relaxin and get it back into its original architecture structure to help relieve pain and also improve range of movement.
Fantastic. Thank you so much for all that amazing information. Thanks to our audience for all the amazing questions, and Dr. Carson for the amazing answers. That is all the time we have for today. And if you did post a question in the Q&A and it didn't get answered, we will try to answer it. So please copy it now and add it to the community section in the Hoover platform. And that section will be entitled Remaining Questions from Presentations. So we'll go there, see those questions, and try to get them answered. So again, thanks again for all your participation. If you're interested in learning more about pain and Parkinson's disease, you can check out the episode of APDA's Let's Keep Moving series, and that's on YouTube. And we have a session on back pain and Parkinson's. We'll put the link in the chat. So for more education on this very, very important topic. We're taking a quick break. Don't go far. We'll be back in about 10 minutes to begin our breakout sessions. We have a lot of great options available. Take a look now at the agenda, decide which session you want to join next. Take a break, come back, and we will see you soon.